right, well, let's resume our session. We have a very special talk by our honored speaker, Dr. Shaffrey, on outcomes of adult deformity, what we do well, and where we need improvement. Dr. Shaffrey.
Well, thank you. Fortunately, this is kind of a good news talk, okay? So I think a lot of what we're all doing, we are doing it kind of in a better and better way, and these are my disclosures. So, you know, when we look at things, and this is somebody who had sort of a poor outcome, multiple surgeries, instrumentation cut, was fused down to L5, but had a couple areas of pseudoarthrosis. And what's happening is I think our instrumentation techniques and the stuff that we've even heard today about, you know, kind of the lateral, you know, approach to L5S1, we have an enormous number of tools in our hands. And compared to maybe when I started and SIG started, you know, we used to have, you know, broken screws, broken rods, we had different stuff, and even doing kind of a good job, and there were problems with the instrumentation that we used. But with what's available today, you know, we can do something, you know, like this, and this was kind of a 2-level A-lift case through areas of pseudoarthrosis, and really have a very nice, very well-balanced spine. You can see at the top, I did a VCR, and, you know, and with what we have available, we can do a really good job. But I think what's happening is many of us felt that we began to hit a wall. You know, yes, our screws weren't breaking. Yes, we had the ability to do things potentially in a less morbid procedure, but we had kind of hit this wall. So this is a study that was done from the combined ISSG and ESSG data sets, okay? And so what it looked like was looked over a decade of how we were doing, how we were treating adult deformity patients. And what this showed was that our surgical complications and reoperations had been reduced by over half. And our clinical outcomes measured by things like ODI were at least 50 to 70% better, okay? And so when you decrease complications by half and you improve outcomes by 70%, we're doing something in the right manner. And, you know, and what's happening is there was a time, you know, 10, 12, 15 years ago where there was a real thought that people should not be doing adult deformity surgery. That, you know, adult scoliosis, it was too risky, it was too costly, the results were not worth what it's done. And there's been study after study now showing that it is worth it. But this really shows kind of the dramatic ability by us having communication like what we're doing today of how we can make things better. And, you know, and so this is kind of a case of mine from not that long ago. This is a lady with very severe MS, very debilitated, and had, you know, brain lesions, spinal cord lesions, filed, hyperreflexic, but had, you know, this terrible truncal deformity. And she's sort of semi-supporting herself. And so basically you can see this, but also had just terrible, terrible back pain. And eventually I saw her again and again and again and did lots of non-operative therapy, but she kind of wore me down. You know, and as what we do, you know, I checked her bone density and we ended up putting her on teriparatide for 6 months. You know, we did, you know what to do for this, and I ended up doing this. Now, if you remember, she had a little bit of a thoracic curve going the opposite direction. And I thought it was like most younger people, that upper thoracic curve, because it was somewhat flexible on bend film, was going to bend right out. But what happens is because of her, you know, her disability and whatnot, a neuromuscular underlying thing got worse and worse and worse. So she ended up looking like this about 2.5 years after I did the surgery. So, you know, what do you do now? And I ended up extending this up to the upper thoracic spine. And I said, boy, you know, I've won. That looks really good. She's now well balanced. But were these kind of problems, you can see now she looks like a buzzard with her head drooped forward and eventually developed kind of a chin on chest deformity. So again, the instrumentation at the top kind of had pulled out. Maybe I should have contoured the rod a bit better into it, but I ended up extending it up to the cervical spine. And then, unfortunately, she falls, suffers an atypical hangman's fracture. And then finally, I ended up doing this, for that. And here's a person that, had some back pain. And this just shows you all of the different tools that we have to do something, but something that ended up being tremendously costly and whatnot. And I think that, these are some of the reasons why we've all kind of hit a wall in some cases about making things better. And the trouble is you look at the lay press and they always, the number one thing they say that you shouldn't do is, have back surgery. And this is doctors getting rich with fusions, surgery debunked by many studies. I don't know what studies that they're looking at, but this was a thing about never have back surgery and kind of what's the disconnect from this. So some of the things that we've done, and I think that people like the guys here, SIG, everybody, I don't know a major adult deformity surgeon who isn't just extraordinarily busy. So for me, my next open OR day is in November for a major case. I think probably for SIG and everybody else here, it's probably the same thing. And why is it, people say, yeah, you shouldn't have this done. Why is it that people come to us for these problems? And this is, again, a study out of the ISSG. And what this looked at was the impact of adult deformity compared to a variety of other different clinical conditions, and looked at some factors that kind of drove disability. And what they found was that, a 35-year-old with untreated idiopathic scoliosis basically functions at a normal level. But a 63-year-old, you can see, who's got some coronal and sagittal imbalance, that's equivalent with having an above-knee amputation as far as clinical functioning. And that 78-year-old who's really imbalanced, that's equivalent to being blind, bilateral above-knee amputations with heart and lung failure. And when you have somebody that's coming in who has that severity of disability, and basically the 78-year-old has a higher level of disability than any other recorded thing for any study looking at a disease-related disability. So this is why people are coming to you. And the fact is, as you're balancing things, it really is tough. And I think these increases in fusions and increases in big fusions, or all of us are trying to deal with something that is a very, very difficult problem. And you do some stuff and you try to scare them and you tell them the risks of big procedures, and they just keep on coming back and coming back and coming back. So this is another study that we did looking at complication rates. And what we found was that these complication rates are sobering. And the bigger the case you do, if you add a 3-column osteotomy or if you do a revision surgery, the complication rates just keep on getting higher and higher. And the type of complications are really widespread, from death to stroke to a variety of different problems. And again, as we move into 3-column osteotomies, the complication rates are, as I showed yesterday, are about 80%. And these are real issues. Now the problem is that again you're balancing on one side the horrific disability with adult deformity, and on the other side you're looking at things. If you have a neurologic complication, the results of those complications do impact clinical outcome. This is another thing, looking at the ScolioRisk study, which SIG and I and others have been involved with this and look at. So for me, this is a fairly common patient. This is an 82-year-old, generally good health, lives independently, walked 2 miles as recently as 2 years ago, regularly walked 2 miles, but now she can't make it to the mailbox. She's got back pain, leg pain, severe symptoms of neurogenic claudication. You can see that she's had previous, compression fractures. She's got very, very bad spinal stenosis. And the question is, what do we do for this, okay? And can we safely and ethically operate on somebody like that, or is that the right thing to do? And we've just completed another study where we looked at a variety of different nursing home patients in the Durham County area. And it appears about 40% of people are in nursing homes for predominantly spine-related, pain and symptoms. And so it was the right thing to put grandma into the nursing home and have her lifted into a chair each day. Is that the right thing to do? Or is it for us to try to push the envelope and to do the surgery? So this is a study that we did looking at risk benefit from doing major adult deformity cases. And so what you can see here is as you get into the 65 to 85-year-old range group, the complications are just really extraordinarily high. And in this case, again, we're in the 70 percentile. But if you look at that, and despite the complications, the bottom two slides show that the outcomes are just the same. So what you do in a 30-year-old or a 50-year-old or a 70-year-old or a 90-year-old, how they do by looking at ODI and how they do by numeric pain scores, the people do really well if you can get them through and have them survive the complications. And if you look at the delta, the change of what they were beforehand to what they were after, it is absolutely extraordinary. So when we ask, okay, if we make a decision that we're going to do it, and I think many of us, if we look compared to 10 or 15 or 20 years ago, are pushing the envelope more. I mean, I'll operate on patients with movement disorders. I operate on people with other different, medical comorbidities that I would have never, ever done 20 years ago. And the question is this responsible? So what's happening is that the surgery that I did, 5-hour surgery, 1,300 cc's blood loss, 14-day hospital stay, 4 of them in an ICU. She ended up having a period of delirium. She had ileus. She ended up having a DVT by ultrasound. She went into AFib. She had urinary retention. She had a 28-day rehab stay. And afterwards, her family said, oh, no, she needs to go into assisted living. And the question is, she came back to see me, and her ODI by our measurements is pretty good, 22 at 2 years compared to being in the high 50s beforehand. And the question was, is this the right thing to do? And was this good or bad as far as the outcome? So this is a recent study. SIG was one of the lead people for this, the PED study, and this is the AO-driven thing. And they basically looked at elderly patients. These are all patients older than 65 who ended up having major surgery. And what they found was that, the people, as we would have thought, who had, worse baseline health status, more difficulties, are the ones who had the biggest problems with surgery and were less likely to reach MCID, a clinically beneficial outcome from what their surgeries are. And I think that as you heard a bit from Chris Ames, a lot of this is related to the concept of frailty. And frailty is the ability for an individual to bounce back after an insult. And what happens is if you have multiple complications and multiple insults, this is where people really have the trouble. But if we can do it and do it in the right way and do it the first time, what you're going to see is that we can have really very predictable outcomes, even in patients who have some medical problems. So one of the things which is present is how do we understand this? And Sig touched upon this a little earlier. Is that what we can't have is we can't have these horrifically involved assessments involve oxygen utilization on a treadmill and this, that, and the other thing. We have to be able to go and figure out how to go and determine how frail someone is and whether we can alter that frailty. And this was a study looking at major GI surgery procedures. And what they looked at is they looked at this multi-dimensional frailty score, and they looked at some factors including nutrition and other things with this. They did a simple dementia assessment score, pre-dementia assessment score, and they did some other different things with this. And they found that the ability to go and use this assessment was extraordinarily predictive of length of stay, of outcome, and of mortality associated with these procedures. So what's happening is that the fact is both of these ladies here are 79 years old, and the fact is that we could probably predict which of the two ladies is going to do better with the surgical procedure that we're going to do. So what I believe strongly is we're kind of have reached kind of near the top of what we're going to do from a technique and instrumentation perspective. And what we need to do is to make our patients better able to tolerate these kind of operations. And so this is again something that was done through the ISSG for us developing a frailty tool. And that's what Chris has done to use some of his subsequent work that he's been doing, looking at telomere length and proteomics and whatnot. And what's happening is it's relatively easy if you're kind of an ISSG participant because you're gathering all these things, but these are all the different factors that were looked at. And what we're trying to do at Duke right now is to try to have a very much more simplified way to be able to go and do a frailty assessment and to alter those factors of frailty to go and have better outcomes for the patients that we're operating on. Now, I think one of the most interesting things, and of the different slides, this is probably the best take-home message. And what happened is, in this study, we went and looked at patients, and we categorized them very simply as non-frail, frail, and severely frail. And what we found was that the patients that were frail had the biggest impact. They did the best with surgery. They thought that the results were far better. They were the most pleased with the outcomes. Severely frail people did terribly. But we've just done a study that if you can move somebody from being severely frail to frail, they're going to do great, okay? So the fact is, sort of one of the take-home messages, you do not want to operate on severely frail patients. You're going to have terrible results. And if you're going to say, what can we do better? That's the one take-home message. Don't operate on severely frail patients. So one of the things is that you would be amazed, and this is my personal scorecard that Blue Cross and Blue Shield has on me. And so part of what I do in my administrative role is interface, doing a lot of things. We're doing stuff with bundling and other different things. But I asked them for my personal scorecard, how Medicare looks at me. And if you look down the thing, what things they are assessing on each one of us. This is Blue Cross Blue Shield in North Carolina, but I'm sure that San Francisco and every California and a lot of other places you have the same thing. And what they look at is these are different, the number of visits you have and what things you do on, the size of the surgeries and the complications you get after it. And they go and they give you a grading scale about how you are doing. And so people say, Chris, you get I hear from your people that you get 1 in 20 peer-to-peers. And I said, the reason why is that, I am aware of what I am trying to do, and I try to stay within the parameters. That means that they're there. And so you can see this is my thing. These are things that they say I do too much of in their view. I get too many x-rays and I do too many multi-level fusions. But this is my Medicare kind of provider number and what goes on with that. And so one of the things that we do, and I think that other places that are contributing, like UCSF, to the downward trend in complications and the upward trend in outcomes is really having a very vigorous preoperative optimization program. So what we do is we get blood work on people, we assess bone quality, we're doing infection screening. Now we just treat everybody like they have MRSA with decolonization and whatnot, and we make sure that they have adequate social support. And this allows us to go do it. So someone's a smoker, you're not going to get a surgery by me. If your nutritional status is poor, you need to be nutritionally repleted before I do surgery. If you're having poor pain management, that needs to be addressed. And one of the things is you're going to see is we are extraordinarily big believers in prehabilitation, that we have a very, very vigorous strengthening and conditioning program before people undergo surgery. So this has now been standardized through our anesthesia providers and through the entire system now, and it's called the PASS, which is for the people that have a little bit of a problem. We have something called the POSH clinic, or those people that have multiple indices of frailty, and they go through this, and until they pass through that for an adequate optimization, we are not doing surgery on them. And there's a rationale behind this. This is a study looking at blood glucose levels, hemoglobin H1C. And basically, if we don't have a hemoglobin H1C of under 6.5%, we're not doing major surgery on them. And the reason why is it's been shown to be a significant risk factor for wound complications and infection in both total joints and in spine surgery. One of the things is that, this is looking at serum albumin, and the level for this is 3.5 grams per deciliter, the albumin levels. And you would be amazed about how many people are malnourished by this parameter. And so for us, we're doing nutritional supplementation and whatnot to get them up. So I was going to show, this is a study looking out of Duke, and what it found was that being obese is not protective of being malnourished. And what they found in this study was about a third of the patients who were significantly malnourished were also obese. And the reason why is this is a thing that was on YouTube, but this guy made something he called holy water. And that was a bag of Doritos and a 2-liter bottle of Mountain Dew that he would blend up. And he went and drank this for his nutrition for 6 months. And he ended up gaining like 70 pounds, like every health indices went terrible, just went absolutely terribly. But if you walk into I've shown this a couple times, including like a local talk, and the number of people that you walk into your clinic and they've got a bag of Doritos and a big 2-liter jug of Mountain Dew is really scary. So we do some cardiac risk assessment things and optimization, and there are times for them to be on, to reduce risk, for them to be on anti-cholesterol medications. We do this decolonization regularly now on every single patient. We don't even culture them or anything. We just decolonize them with nasal antibiotics. And it's been shown to be a big risk factor in the advantages of decolonization. But the single biggest thing we do is this supervised exercise program. And this was a study that I saw, again, about 7 years ago. And this was a study looking at abdominal aortic aneurysm repair. And if you look at the stresses of surgery and the comorbidities associated with it, this is the single operation that's most closely linked or at the same level as major adult deformity surgery. And what they found was by doing a structured rehabilitation program with these rehabilitation sessions done, and this was just for 6 weeks, where they had 6 weeks of vigorous exercise before the operation. What they ended up finding was, they reduced the amount of postoperative complications by 50%, and they reduced the mortality rate by 70%, compared to the control where they didn't do anything. So because of this, these are two studies that we're involved in at Duke now, doing formal prehabilitation assessment. And I'm just going to tell you, if there's going to be one thing that you're going to do for your patients you've got a question about their frailty, is to get them. I generally do a very vigorous water aquatics therapy program. And if they don't come in with the signed sheets that they had done it, I don't operate on them as far as things are concerned. So, we talk about osteoporosis and its impact, and we are very, very aggressive about checking vitamin D levels, in addition checking to make sure that their bone quality is good. And we're very aggressive with the use of anabolic bone building agents, usually from a minimum of 3 months, but ideally in some people up to a year, where we're treating them with teriparatide or one of its analogs, or Evenity for the treatment for this. And this is just to show it reduces screw pull out, it reduces non-union rates, and do there. The last thing is perioperatively, we're really doing some things to go and alter what we do in the operating room. And this, we realize that there's a very strong association between significant blood loss and perioperative complications. And because of that, we are doing things preoperatively as part of these clinics to make sure they're not on any kind of medication that would go and affect blood loss. And this is something, again, a kind of a North Carolina thing. You ask, are you on an anti-inflammatory? No. Are you on aspirin? No. When they come in, they bled like crazy during surgery. And you say, are you sure? And they said, no, I was just taking that Goodies powder. Everybody thinks the Goodies powder, which is aspirin, is somehow some miracle drug because Richard Petty, did that. We are very aggressive with the use of antifibrinolytics. Basically, the standard dosage that we use for tranexamic acid is a 50 milligram per kilogram loading dose, followed by 5 milligram per kilogram per hour maintenance dose. And it's been shown that it really reduces blood loss. These are several studies looking at it in children and adults, and it really has been shown to reduce blood loss at about 50% rate. And then we use something in our hospital called ROTEM. Some places use something that's called TEG, but it's an intraoperative clot integrity assessment. And I'll tell you, it has revolutionized how our anesthesiologists treat. And there are people that at the beginning of the case, that they will go and have a very low fibrinogen rate, and they will instantly give them before we've even cut skin, they'll be giving them cryoprecipitate. And the number of patients that we have had that have gone into sort of kind of DIC picture, I don't think we've had one in 6 or 8 years, where I will tell you, I had some big cases I would do, and suddenly you're operating in the red Kool-Aid, and nothing's clotting, nothing's going on. And this has made a huge, huge difference. And this is the ROTEM. Again, the anesthesiologist is from UVA, and I were involved in doing something called transfusion-directed care, both based upon the ROTEM results, and it had an enormous reduction in blood loss. But why the hospital was happy about it was an enormous reduction in what was being transfused. So they moved from dumping a bunch of FFP and using a lot of crystalloid and whatnot to using cryoprecipitate and using a more colloid-based infusions. And our blood losses, as you can see, decreased by more than 70%. With a combination of the TXA and the use of the ROTEM. One of the things that we're looking at is, looking at predictive analytics and a simplified predictive analytics. I think you heard 2 days ago from Chris Ames, who really is kind of the leader in this field. But what's happening is we can predict very accurately who's going to have a complication. And by knowing what we can do, we are in the process of now doing something called a risk adjustment model, where we can look and say, hey, if you do this, this is going to be the impact on your eventual outcome and your rate of complications for that. So this is something that is called Pythion. How many people here have Epic in their electronic medical record? There's something that they can unlock called Pythion, which is an automatic risk generator that is present, and it's locked in a lot of people's thing. I don't know if you have to pay an added fee, but with Pythion, we are looking and it's showing that its accuracy is as good as what we did with the ISSG, and this is automatically calculated for you. You don't have to do anything. It takes a lot of the information out of the EMR and allows you to be able to do it. Again, part of what we're doing through the ISSG is to do some relatively simple fragility testing, including things like sit-to-stand testing and using ergometry to try to go and do it so that everybody can, you spend $15 on Amazon for an ergometer to be able to go and have the ability to get the same assessment and risk that we're doing with this. This is kind of the future, some people feel, and this is looking again at proteomics and other different factors to see if there's a way to be able to go do that. But when I say this is good news, we are doing things much, much better. And I think that for the people that are still struggling a little bit, enacting some of this patient optimization things will really do this. And this is, again, the results, the outcomes from the PEDS group. And again, SIG and others are really leading the charge in this. But the results that we've gotten are really, this is just a brand new publication, but the results of this are spectacular. So the fact is it's usually not a technical problem now that's limiting our ability to do better. I think it's us doing better and better in patient optimization. And I really will tell you that, the last 3, 4, 5 years, this is what's made the difference in my outcomes. And when I'm able to see it and be able to track how I've done compared to 5, 7, 10 years ago, it's enormously gratifying to be able to help so many more people with their adult deformity. Thank you. Any questions, please?
Great talk. Quick question. I saw in your optimization labs, your standard ones, you have vitamin D for every single patient. I've also seen the counter argument that you should just be supplementing everyone with vitamin D without getting the lab because of the incidence being so high and the cost effectiveness of supplementation being so good. I'd like to hear your thoughts.
Well, I think it would be ideal if everybody was supplemented, okay? But I mean, your average adult deformity patient, at least in mine, is fairly pasty and that they've been, stuffed in the house for way too long. There's a lot of things if we go and like everybody should have whatever their colonoscopy every 3 years and whatnot, what people should be doing and what they do are different. And so what's happening is that's sort of a secondary check. Ideally, we'd like to have them on that. And we kind of have and I probably should add this to the talk, we have kind of a check sheet that we hand out, kind of a plasticized version, and say, these are things that you need to do to optimize your medical condition. And a lot of the lead up, and I will say the average person that I'm operating on with adult deformity, I've seen them between 3 and 6 times. So we're starting, this thing of trying to get them into conditioning, water therapy. We've sent them for bone densities. We use a fair degree of quantitative analysis using Hounsfield units on CT scans. So we're doing these different things. So we're trying to slowly creep them over a 3 to 5 to 7 month period of time to try to get those things optimized. Smoking cessation, if someone says that they've been a smoker, we check them on several occasions for nicotine byproducts, just to make sure that they haven't slid back or doing stuff. The nutritional thing is really big, and you'll be amazed if you start checking nutritional parameters, how malnourished a lot of these patients are. So the answer is yes, they should be on vitamin D, but that's a sort of a double check. And then we say, hey, we're prescribing it for them, and we're going to recheck them before we proceed. And that's why our anesthesiologists have done such a great job partnering with us, because they'll recheck them and recheck them and recheck them. Since I've been here, I got paged 2 nights ago at 2 a.m. I'm like, what the hell is, my pager goes off and it goes like, it goes, Dr. Shaffrey, I'm so-and-so, I'm scheduled with you on our case on Wednesday. And we'd gotten this guy's hemoglobin H1C under 7. And he went to his pain doctor because he had a flare up, and he's given him 3 different injections. And now his hemoglobin H1C is now 9, and they did a spot check, and it had a glucose of 400. And I said, no, we're putting him off. Thank you for checking and rechecking. So, we've got some strict rules, but the reason why, and people get all, ticked off, if you look at me on, Yelp or whatever the hell the rating thing is, there's always, I've got these different ones, that asshole told me I couldn't, have surgery until I quit smoking, and, FM and, those kind of things. But then again, they're the first people who are going to complain if they have some kind of horrible complication. So all of these things, we're checking all of them. So it's not, the vitamin D is a small part. The more, the bigger problem for us, and we're just hiring sort of another bone health expert to be able to work through, because the worst thing, these people that have a T-score of their, and I usually say get their non-dominant wrist, but they'll have a hip T-score of 2.3, and they haven't had a fragility fracture, and that they're a setup because of sarcopenia and other things. They're a setup to having fragility fractures or PJK or whatnot, and trying to get that approved takes a monumental lift. At least it does in North Carolina. Seg?
Chris, excellent overview and encouraging news about how outcomes are improving and complications are reducing. I think there's no question your data is compelling, and we actually just published an article in Spine Deformity Journal, a systematic review of evidence regarding preoperative optimization. Now, having said that works well for a discretionary surgery, right? So it works well for patients who don't have a progression of a neurologic deficit, who don't have a rapid progression of deformity, who aren't myelopathic, who don't have tumors. So for cases that are truly discretionary, I think there's little argument that we ought to optimize these. But I'm interested in your perspective as a leader of a healthcare system. What happens when, A, the case is really not discretionary, so we've got a progressive neurologic deficit, somebody's myelopathic, and B, what also happens, and how do you deal with this as a leader, when somebody isn't booking out their schedule till November? In fact, I got a little time in 2 weeks, and golly, this patient's not going to quit smoking, and this patient's not going to have their blood sugar improved, and I get paid regardless of what happens. So at what point, how do you enforce this optimization, and also what happens in a patient where surgery is not a discretionary procedure?
Well, so there are some cases where you're just going to, that you're going to have to take a risk. And so a lot of times what I'll do is, for example, if I have somebody, and you most commonly see this in a cervical case where they have, multi-level cervical, compression. And for them, they bought a front back operation, but they bought a front back operation, and and the hospital has to know that they're going to have a negative pressure wound dressing on the back of their neck, and there's going to be a bunch of different things to do for that. I'm just going to tell you, that thing that I showed you, and I've got a whole separate talk where it's a lot more detailed. If you don't believe that the insurance companies are looking at you and looking at your outcomes, you are really mistaken. I mean, what I'm going to say is Silicon Valley and California and whatnot, I'm sure the level of sophistication, here I am with, with Barney Fife and here I am in Mayberry, and they know exactly the number of readmissions I've had, and it's any readmission anywhere. They get the data to, if they've had a complication, if there's a reoperation, if I have a deep wound infection, if I have anything, they know all of that information. So the bottom line is, if you're pushing the envelope, it may not be this month or there, but eventually someone is going to come down on you. And believe you me, that the federal government, when they're looking to go and to cut all of these costs, there's nothing that they would rather do than to come down upon the poor, the poorly performing, poorly performing doctor. And some of this stuff, public perception, if you're operating on the sickest of the sick, you are really you're going to have more complications. So back to the thing, and I'm not going to mention names or anything else, but we had a doctor at Duke who I felt was a true humanitarian, was somebody that would operate and see people that nobody else would see. People with Parkinson's disease, people that, that they'd had some kind of horrible, paralysis as a child and had horrific deformity, and operated on people who were really, really sick. And many, he's one of the people that didn't do any screening. He took all comers, self-pay, Medicaid, whatnot. And basically, he ended up getting in incredible trouble with the state medical board and locally due to the number of complications that he had. And I felt, and I had kind of vigorously defended this individual, saying, look, he takes care, he's Mother Teresa, okay? He really is. And these are people that nobody else will touch. But I'm telling you, it didn't protect him from just going through abject hell. And so what I would say to you is, again, if you're somehow in the 25th to 75th performance range, you're probably not going to get scrutinized. But if you're doing really big cases, most of the people in the front two rows, you have some bad outcomes, and it is something, and it was a sort of a totally different case. But I had a patient that died on the operating, sort of quasi died on the operating table. He was off the operating table, but an hour after surgery, somebody that died. And, and thank God I've had 5 years of really goodwill, because I'll tell you, if it was somebody that was just starting, it would have been, there would have been hearings and root cause analysis and everything else. With me, they kind of just said, oh, well, that happens now and then, and kind of swept it under the table. We did it at M&M. But I'm just telling you, you start having high levels of readmission and whatnot, the chance for you having trouble. And that's why I said, I think optimizing, it's the right thing to do, except for the sickest of the patients. But even many of the patients, maybe not with a tumor with cord compression, maybe not with profound myelopathy, but there are some things that you can do for 2 weeks to go and get them on nutritional supplementation, some other things. There's some things that they can do, and even admit them to the hospital, which I've done, to get their their blood glucoses down to a reasonable level. That I've gone and admitted them and say, look, I don't care. They can sit on the medicine service for 2 weeks until they get their blood glucoses down to a reasonable level. But I wouldn't rush into something that's quasi-elective. If somebody has a Hoffman's, okay, I'm going to tell you they're going to get optimized. If they can't walk or they can't feed themselves, then you may be put into the position. Sig, what do you do for it?
I think what you're pointing out here is that the risk stratification probably isn't adequate. So when you're looking at large data, the ability of Blue Cross in North Carolina to say, hey, here's somebody who's distinctly different, severely frail, than somebody who's moderately frail, right? Probably that degree of granularity doesn't come out. What they look at is, hey, here's somebody who's got a 12% infection rate versus somebody who's got a 1% infection rate, without stratifying the data. So, I think in my hands, certainly I'm making that distinction between what's elective and what's not. And as you point out, quasi-elective doesn't count as emergent. So I'm spending a lot of time. I've got patients who have been, certainly more than a year, in some cases 3 years from their first visit, who haven't quit smoking, who, in an example that the fellows will recognize recently, patient is myelopathic but hasn't quit methamphetamine use, right? That's a pretty obvious one. And those patients, in general, are waiting. But I think the reason for that isn't so much concern about the rating on a Blue Cross, but rather recognition of how severe the odds ratio is of complications on these patients. And if they can't comply with stopping methamphetamines, if they can't comply with stopping smoking, then they're probably not going to comply with the postoperative regimen either.
Good. Well, thank you all. Hopefully that's something that you'll take back. But I would tell you, if nothing else, 6 weeks of prehabilitation, it'll probably reduce your complication rates by 1/3. So please take that home with you. Thank you.